to the launch of the latest season of Emory University's Health Storytelling Project, a Q&A series with authors of fascinating new books about health and science. I'm Maryn McKenna. I'm a journalist and author and senior fellow in the Center for the Study of Human Health at Emory University, and I'm the curator and host of this series. In a moment, I'll introduce you to my guest, science writer and editor Quinn Eastman, and his fascinating brand new book from Columbia University Press, The Woman Who Couldn't Wake Up, Hypersomnia and the Science of Sleepiness. But first, let me tell you about this series. At least once per month during the academic year, we invite writers whose journalistic or academic books examine health, the science and history of health, and health's intersection with society. This series of conversations originates at the Emory Center for the Study of Human Health, and the entire year of productions is co-sponsored by the Georgia Center for the Book, an affiliate of the Library of Congress, and Science Gallery Atlanta, which presents exhibits that live at the juncture of science and art and ignite creativity and discovery. And this year, for the first time, we are joined by a new co-sponsor, whom I am absolutely thrilled to announce: the Decatur Book Festival, the largest independent book festival in the United States. Book fans may know that the Decatur Book Festival is taking a post-pandemic hiatus to rethink its goals and strategies. And in that pause, we are delighted to bring these authors in our series to the festival's passionate supporters. So let me tell you who will be appearing. Our theme this semester is how patients identify illnesses that medicine initially does not recognize, and how patient communities are forced to become their own advocates and persuade researchers to collaborate with them. Tonight, as I mentioned, I'll be talking to Quinn Eastman, a biochemist and science editor and journalist and author of The Woman Who Couldn't Wake Up. On October 5th, I'll be in conversation with Jennifer London, an essayist and cultural critic who lives in Maine, whose new book, American Breakdown: Our Ailing Nation, My Body's Revolt, and the 19th Century Woman Who Brought Me Back to Life, interweaves London's experience of mysterious fatigue with the story of the brilliant, witty 19th century diarist Alice James, who spent much of her adulthood bedridden. And then on November 2nd, I'll talk to Amy Doxer Marcus, a Wall Street Journal reporter and Pulitzer Prize winner, whose book, We the Scientists: How a Daring Team of Patients and Doctors Forged a New Path for Medicine. That book explores how a group of parents whose children had been diagnosed with a rare and fatal genetic condition transformed themselves into citizen scientists to reach for a cure and save their children's lives. So this series, it's live streamed on YouTube, Facebook, LinkedIn, and X, formerly Twitter, and archived on YouTube, where you can find all of our past seasons. And one note about that: if you are watching us on September 7th, you are experiencing a live event. You can interact with us, and we encourage you to do that. If you're watching on YouTube or Facebook, your comments will come through to our live stream platform. We apologize that this integration doesn't work for Twitter anymore. Twitter broke that. But you're welcome to post your comments and tag our account. If you comment, our producer, Stefan Kaplan of Spin It Social, will make sure we see what you've said, and we'll put your questions up on screen when I pose it to our guest. Do note that I'll turn to your questions in the second half of this 60-minute live stream, but you can put your questions in at any time. Now, let's turn to our book and guest. Quinn Eastman is a biochemist with a PhD from Yale. He is a science editor and a journalist who's covered a wide variety of topics. And he is now the journalistic expert on idiopathic hypersomnia, which we're going to talk about. Quinn, welcome to our storytelling series.
Thanks, Maryn.
So have so many questions. It's such a good book. Thank you so much. The first, of course, as always, is just tell our audience a bit about yourself. Tell us how this book came about and how you came to the topic.
Ooh, I'm kind of a biochemist by training a long time ago, but then, my postdoc hit a wall, and then, so I kind of decided to redirect and head into journalism, and I was a newspaper reporter for a while, and since 2007. I was a biomedical science writer at Emory, and this story about Anna, the titular woman who couldn't wake up, was started even before I got to Emory, um, and I actually owe my friend Carol Clark the kind of she got the basics when one of the people involved gave a lecture about Anna's case in 2007. But then, so this was kind of floating around for a long time, and I eventually went to a lecture given by David Rye, who's kind of one of the main characters in the book, and got to know Anna and Rye and a lot of the other players, and and then explaining how Anna's story fits into the larger story of the diagnosis of idiopathic hypersomnia. That's the challenge, right? And so that's kind of what the whole book is about. Is about where there's this category of sleep disorder diagnosis called idiopathic hypersomnia. It's been around since the 1970s. But until about a decade ago, there wasn't really much of a community as far as support groups and advocacy organizations that could speak up for these folks. And even among physicians, it didn't really get that much respect.
So that's a great place to jump in. And I want to talk about all of these characters. But a thing I wanted to say to start that I think is so fascinating about this book is that I think it's fair to say that Americans, at least, are kind of obsessed with sleep. And I have to say, I am coming to this conversation a little sleep deprived myself. It's close to the beginning of my semester. My car and my water heater both blew up today, and it's been a little busy. And so when I went and looked up some of the links related to your book so that we could tell the audience about them later, I noticed that there are so many books about sleep. There are books about how to sleep better and how to sleep more and how to sleep less, but in a more optimized way, and how to get your child to sleep, and probably an infinite number of books about how to persuade babies to sleep. We are so passionate about sleep, or as a culture, that we even have a National Sleep Week, which, if I remember from when I was a newspaper reporter, I think is sponsored by mattress manufacturers.
Yeah.
So sleep is obviously something that we all want to know more about. And we probably mostly feel like we don't get enough sleep. And here you have a character, multiple characters, who actually have the opposite problem, that they can't stop sleeping, whether or not the sleep is good for them. So how did you feel that fascination when you entered into this?
Oh, yeah. But it was more like it was this insidious thing where where it's kind of sleep is taking over more and more of their lives. If a child is supposed to go to bed earlier, if a child is sleeping 10 or 11 hours a night, that's great. Right? It's good for their parents. They have something else to do. But if an adult is sleeping 11 or 12 hours a day, I mean, actually sleeping, there's the whole different thing about people who spend a lot of time in bed because, they don't have the motivation to get out of bed, or it just hurts too much or whatever. these are people who are actually asleep 11, 12 hours a day. And they feel sleepy even when they're out and about trying to do stuff. I remember arranging a meeting with someone who felt uncomfortable driving for more than about 20 minutes, right? And then thinking about how that would limit anyone's life. And then they experience this thing. Some people experience this symptom called sleep drunkenness, such that it's sort of this half awake state that lasts a long time after you wake up. So it's like sleep just seeps into every part of life and kind of takes it over.
So the thing that struck me a moment ago when you were talking about how you first discovered this story is that this was not a very well understood or well recognized condition. And I think any of us who have been around healthcare for a while can remember other conditions that's the case for, that emerged, that were not well known, that in many cases people had to convince medicine that their condition actually existed. Lyme disease at the start, myalgic encephalitis, chronic fatigue syndrome, most recently, long COVID. And so I'm imagining that since you were around at the start of the recognition of this condition by the research establishment, with that first announcement in 2007, and then the first paper in, I think you said 2012, you must have witnessed this some sort of confrontation between people who were convinced that they were seriously ill and a medical establishment that maybe wasn't quite ready to receive that news.
Well, it's a little more gradual than that, because idiopathic hypersomnia as a diagnosis was always kind of obscured by something else, narcolepsy, that was better established. There were FDA, for decades, or at least a couple decades, there were FDA approved medications for the indication. There were support groups. There were, it's been known since the 19th century. And what idiopathic hypersomnia has been is sort of the shadowy sibling that is not as well known. And the sleep medicine field, it was more oriented towards narcolepsy. And so there were lots of people who, for example, told their families or told the insurance company that they had narcolepsy because it was easier for them to get the medications that they needed,
even if they were not exactly the right medications.
Whether they were, it helped them. It allowed them to get through the day for a while. But you were making that comparison about chronic Lyme and ME/CFS. I think it's a good comparison to make, but I think sleep medicine always recognized there was this thing called idiopathic hypersomnia, but it was never a full. Until recently, it was not a full thing. It was just kind of this, like the leftover bin. And then over the last decade, that situation has changed.
And we're going to talk about that evolution. But I just want to remind people who are watching us, I can see there are lots of you. Thank you for tuning in to this live stream. If you are on Facebook or YouTube, possibly also on LinkedIn, you can comment and we will see those comments. If you're watching us on Twitter, you can comment in by tagging our account, and we will be searching for all these comments. If questions are occurring to you, you can pose those questions now. I won't pose them to Quinn until we're a little bit further into this hour, but don't forget what the thing is that you want to ask write it down now and I will see it. So, Quinn, I'm really interested to hear about some of the characters in this story, because you begin with the woman who's the subject of that first paper, but then a community coalesces around this condition, and then other members of that community actually sort of carry the torch forward, and that's a really interesting narrative to me, that it's not a single crusading patient, but a group kind of holding each other up.
Yeah, that was a bit harder to sell as far as, like, you know, a book proposal or whatever, but it's really more illustrative of, it really takes a community of people to band together and say, we have something that is not well recognized, and demand more attention for it. And that's what I'm hoping is one of the key messages for people who have chronic illnesses, that you might feel alone if you know, your doctor doesn't take you seriously, your insurance company doesn't take you seriously. But if you have 1,000 or 10,000 allies, then they will take you seriously.
So one of the aspects of taking you seriously, I would think, is that you become visible to biomedical research, and potentially you become sort of imagined as a possible market if drugs can be achieved. And there is a point in this story in which researchers, of course, have been involved with individual patients for a while, because there is that seminal paper that brings attention to this. But as the community collects, there's more interest, and particular researchers who sort of rise out of this interest and really become strong characters in your book. So talk about them.
Well, the early few chapters are driven by action at Emory, which is, you know, we have Anna, the woman who couldn't wake up, right? And she had an experience which was thought to be kind of exceptional, that she responded well to this oddball drug that the doctors tried. And when it turned out to be good for some other people, not everybody, but at least some people with these hard to treat sleep disorders, then the light bulb went off for the doctors, and they said, hey, maybe there's something here. And that the problem was that the drug that Anna responded well to was already out there. It was patented, and it was old. It's called flumazenil. It's an antidote for benzodiazepines. It's kind of if you're sedated with anything from, you know, like if you go to the dentist or getting another medical procedure, what flumazenil does is that it wipes the sedative away. But if you just give it to somebody who's already doesn't have drugs in their system, it's not supposed to really do anything. And what was kind of remarkable was that Anna responded very well to this thing, and it made the doctors think there's something in her system that is like a benzodiazepine. And then they tried this with other folks. They found biochemical signs that there was something in patients' spinal fluid. And then they went on this. Starts this whole detective story about what is this stuff, and that is never resolved, at least within the book itself, and it still hasn't been resolved. But what it shows is just that this drug was different from a kind of a conventional stimulant, which is what people with hypersomnia type disorders were generally prescribed. They could get through the day, maybe, but after a while it would stop working. It made them, depending on who you're talking to, it would make them too jittery, or I mean, I remember talking with someone who said that she couldn't even eat something because her hand was so shaking so much from taking so much Adderall just to stay awake. So it was an alternative to conventional stimulants, and I think the field still needs alternatives to conventional stimulants, and those are coming. And that's another broader theme that I think that the people, like that the Emory people, recognized, and they tried to follow. They later hooked up with a company that was testing a similar drug that worked in a similar mechanism, but was and that kind of meeting of the minds that drove the first clinical trial for that included people with idiopathic hypersomnia. And that's another thing that I hope that the book will do, is to kind of mark that company, which didn't make it, was later dissolved, was the first one in the space. Because right now what's happening is, now that there's this other strange drug that works by a different mechanism that was approved in 2021 for idiopathic hypersomnia. It was the first. What happens is drug companies can buy ads on the internet, and they can kind of define what people see, as far as when they go looking for what is this strange thing that the doctor told me that I have, that they can define it. So what I'm hoping is that this will kind of provide the backstory that is independent of that.
So as these drugs were worked on, we talked a little bit about Anna, but there must have been other patients for whom these worked well or badly. And I think you definitely met some of them. So are there other patient stories that you can tell us about how people, as they moved through this experience of forming a patient community, how they discovered that their experiences of being treated for this were not all the same?
So Anna was the first person to be treated kind of chronically with flumazenil for a sleep disorder. And she was like the only one for a few years. But eventually, David Rye, neurologist at Emory, main character in the book, kind of got worn down by the patients who wanted alternatives. And he said he was just tired of kind of posing a bleak picture to them and saying, there's nothing else you can try. So he started prescribing this, basically off-label, but it was available. It was available through a compounding pharmacy, which is sort of this gray area that you can get since it's approved kind of as an antidote. You can, a pharmacy can get it. They can make it into these little lozenges that people take, or a skin cream, actually. And then people could take it that way. And then there was this kind of underground movement of people taking flumazenil for sleep disorders. And it was driven partly by social media.
Tell us more about that.
There was this fellow in Australia, Lloyd Johnson, who started a website called Living with Hypersomnia. It's not active anymore. but the kind of the hypersomnia community kind of gravitated to this, and then there was a Facebook group and other things like that. People started starting new groups and kind of. I mean, there was always stuff for people with narcolepsy, since before social media. But then they kind of crept in around the edges and then said, "Hey, we should start our own thing." And then they started talking to each other about these alternatives, and that was kind of one of the main venues for this community coming together, first online and then later in person.
I know as a journalist and also on behalf of family members, I've spent time in particularly Facebook groups that have been put together by people who suffer from chronic illnesses of various kinds and who talk back and forth about, my symptoms are this. Does anyone else experience that? I've tried this as a treatment. Has anybody else heard of this? I saw something, out there on social media that sounds like it might be promising. Do you think this is fake? And those kind of exchanges are incredibly powerful and really empowering for people who have something that's either not otherwise recognized or not well defined. And so did you spend time in those groups? I know you said you went to the very first conference that was ever organized for idiopathic hypersomnia. And so you must have had a real immersion in these patient communities.
Well, I was a lurker for a long time. And I also I never kind of mixed it up with people because I didn't want to kind of throw my weight around as a representative of Emory or something, because that would be just seemed inappropriate. And also, like, I have sleep apnea. I experience kind of a mild version of what people with hypersomnia experience, in the sense, what I tell them is, I see what you experience through a keyhole. And so I could certainly relate to what they're experiencing, but it's not the same. And so I was lurking for a long time because I was kind of, I don't know. One of the researchers was also a member of one of the Facebook groups, and I thought, well, if he's a member, then I can be a member too. So I would see it all the time, but I didn't really get. Also, you have to be really careful about, not kind of ambushing people based on what they say on social media, because, they expect it to be kind of a protected space, right? So I think what I would use the Facebook group as being kind of as an issue spotter. Like, if I would see a lot of people complaining about something, or then I would say, okay, that's an issue. But I would always kind of approach people kind of one-on-one to say, hey, I'm working on this. Can we meet? Can we talk about it some more?
And how did they react when you did that? I'm assuming you DM'd them, you emailed them.
Yeah.
And were they offended that you'd been lurking, or did they feel like this was a chance to talk about their experience that no one else outside this community would understand?
Well, the other thing, I had some help because I had at that point built up a good relationship with people like Diana Kimmel, who was the organizer of the Atlanta hypersomnia support group. And then some, like, it's varied. Some people are happy, that, you want to tell a story about something that is not well recognized. That's great. I don't think you're being exploitative or anything. That's just go ahead. But other people, they want to tell their own story, and that's okay.
Tell us a bit more about Diana Kimmel, because I think if I remember the book correctly, even though the book begins with Anna, Diana Kimmel becomes more of a face of this disorder as the narrative goes on, right? She's comfortable in the spotlight. She
Well,
has a good experience.
only recently did Diana kind of become a board member for the Hypersomnia Foundation. But yeah, if you organize the support group and you organize snooze cruises and all the things that Diana does, then eventually, yeah, you're kind of comfortable with being the focus of your.
Okay, we need to hear more about snooze cruises.
I have not been on one, but that's the idea. Is that it's on a cruise ship, and then if people with hypersomnia want to get together and go on a cruise together and talk about the issues that they face, then that's a good setting because you can always take a nap when you need to.
I'm going to remind the audience again, thank you all for listening. We can see all these listener numbers on our dashboard, and it's very exciting to know that you're here with us. So thank you. If you have questions about what Quinn is talking about his book, The Woman Who Couldn't Wake Up, about the condition of idiopathic hypersomnia, about the experience of encountering a new patient community and watching that emerge, please put your question in the comments. You can't come on camera. I'm going to relay your question to Quinn, but we'll put it up there on the screen so everyone can see it while we talk about it. So Quinn, a couple of times you've mentioned a researcher, David Rye, and it feels like he is really important to this story. He is someone who really takes this seriously and takes the condition on as something he's going to devote research time and attention to. I would love to hear more about him.
I'm hoping that the book conveys just what kind of a character he is. He's still seeing patients at Emory, although I understand he's not a full-time clinician at this point. I think Rye was shaped partly just because he was a kind of a maverick character, but also because he had this experience that what he was into before hypersomnia was restless leg syndrome, and that also was not fully taken seriously. I mean, you can remember kind of people making jokes about it, saying, "Is this real?" And so he was comfortable with that. The thing that he was interested in, lots of other people thought was bogus. So he was down with that.
So he began prescribing to members of this community that first drug, that existing old drug that was being used off label. But then does he become part of the research effort to find a new drug? You said there was a clinical trial.
Yeah. Yes. There were some issues where, because they were trying to commercialize, there was an issue that he couldn't be the principal investigator for a clinical trial, but there were more people involved besides him. They had the detour, and I don't know whether it is a detour, but they found this other drug by chance. Anna had responded well to flumazenil, and then she took an antibiotic because she had bronchitis, and the antibiotic is called clarithromycin, and this made her have insomnia for she couldn't sleep for 3 days. So the idea was that if she responded well so strongly to that, then it must have a wake promoting effect. And so the hypersomnia community took up clarithromycin, which was more available because it's an antibiotic. you can get it, the doctors can prescribe it easily.
An old antibiotic, not something new on the market, right?
Yeah.
Something that would be generic and relatively inexpensive.
Yeah, and then the clinicians, all one of them, Dr. Trotty, always expresses kind of misgivings about this, saying, I look forward to the day when I never have to prescribe clarithromycin again, because of concerns about antibiotic resistance, which a lot about. And then but it was kind of self-limiting also because clarithromycin gives lots of people a bad taste in their mouth. It makes them, they say it's like having metallic objects in your mouth all day.
So we had this original drug, this old drug that was used, and then people adopt this old antibiotic. But we still haven't gotten to the point in the story where there's a clinical trial for what is presumably something new, right? So where does that come from?
The clinical trial was from a company called Balance Therapeutics, and Balance was started at Stanford, and they were investigating a drug called pentylene tetrazole. And that has a weird history all by itself. In the 1930s, psychiatrists gave it to people with schizophrenia in huge doses to trigger seizures. But then if you take it in a kind of by mouth, then it doesn't cause a seizure in a smaller dose. Anyway, what Balance was doing, was originally looking for, was a medication for people with Down syndrome, to basically as a cognitive enhancer. And it works by a similar mechanism in that it inhibits signals from GABA in the nervous system. So GABA is sort of one of the main inhibitory neurotransmitters. And if you inhibit the inhibitor, then it's activating.
So I think our audience is probably going to need a little more explanation about what a neurotransmitter is and what inhibition means.
So when you fall asleep, there's a certain part of your brain it's part of the hypothalamus, that is sending out signals to other parts of the brain, and those are inhibitory, and it's through a neurotransmitter called GABA.
So it's shutting your brain down.
Yeah, it's sort of telling other parts of the brain, calm down. And the idea is that if in someone with hypersomnia, that these signals are too active. So the idea is to kind of turn those down a bit.
And the clinical trial?
And the clinical trial there were 2 clinical trials sponsored by Balance. And the results were never released. There are people who I know who had like Diana Kimmel, who had positive experiences with pentylene tetrazole. They said it was great. Lots of other things didn't work for them. But in terms of, if it was a great success for enough people, we would have heard about it, because the company would have brought it to the FDA. They would have asked for approval. So it's kind of one of those mysteries of science, why some people respond well to this drug and other people don't. So
this is a really interesting story to tell. That's one of the things that I found so fascinating about it, is that in several different ways, the narrative structures that we expect for a story about medicine, for instance, the detective story, right? That something has happened and some brave investigator is going to figure it out, and they follow all the clues and they figure it out and we have an answer. Or the kind of the brave and somewhat wacky investigator, right, who has an idea that nobody else believes, but they fight through all their experiments and they prove that it's true. Neither of those really happen in this story, right? You have a detective story that doesn't get resolved, and you have a clinical trial that feels like it ought to be the big hope for people, and it doesn't end up quite like people want. Those are two profound narrative challenges for a writer.
Yeah. And to be clear, I didn't know what the result, when I started working on this project, I didn't know what the result of the clinical trials would be. And it was only because there was this other medication that kind of swooped in out of left field, and it succeeded, that kind of made the story have this natural ending.
Mm-hmm.
And that now what I would like to compare it to, although I don't know if some of the people involved wouldn't like the comparison, is that in the 50s and 60s, there was a group of people who, there was this multivitamin theory for schizophrenia. The idea that that people with schizophrenia have a vitamin deficiency, and if you give them a lot more vitamins, then they'll improve. But at that and there was this, so this came along at the height of Freudian influence in American psychiatry. So that's when you had this idea that it was the parents who make their kids have schizophrenia.
It was the mothers, right? Mothers were blamed for this, yes.
Which, the families didn't like that. So you had these people like Osmond and Hoffer, and they had this theory that there was a kind of a metabolite of norepinephrine called adenochrome, and it was a hallucinogen, and there was too much of it in the brains of people with schizophrenia. It was sort of the theory that they have in my book is about the sleepy stuff. And
that's a very technical term.
Right, the sleepy stuff. And the theory that they had about schizophrenia back in the 50s and 60s was the hallucinogenic stuff. And that theory didn't work out, but it was this biological alternative that was attractive to families, like people who were, the parents of people with schizophrenia said, I don't want they're tired of having the doctors blame them, so they organize there's a group, the National Alliance for the Mental Illness, NAMI, I don't know the exact acronym. And and those families gravitated to that, and they built up this, and they built the community. So the scientific theory didn't work out, but it built the community. That's the parallel. Does that make sense?
Mm-hmm. Yeah, it does. So, but I have to track back to something you said a minute ago, because we were talking about the clinical trial and how it apparently didn't work, since the trial was never reported out and the drug was never brought to the FDA for potential approval. There is no new drug for this, but you said that something swooped in. So what's the thing that swoops in?
This is a medication essentially that was approved for narcolepsy about 20 years ago. It's formerly called oxybate, which is kind of a highly regulated version of GHB, gamma hydroxybutyrate, which is this fast-acting sedative. And there are thousands of people with narcolepsy who take this every night, and it helps their bodies get good sleep, and they feel better and more awake during the day. It's still, despite lots and lots of research, this thing was first identified in the 50s, kind of as a drug. it's not really clear how this thing works. Like why, even when it's kind of washed out of the body, why does it help someone stay awake the next day? So this was approved about 20 years ago for narcolepsy, and then the company now called Jazz Pharmaceuticals that manufactures it, they developed a low sodium version, and when their primary goal was to get it approved for narcolepsy, but then kind of along the way they said, okay, well let's do it for idiopathic hypersomnia too. And at that point, the patient groups were organized. The sleep medicine specialists were more attuned to the need for an alternative, for an FDA recognized medication. So it came through.
Because it already had an established history, a clinical history. People had been taking it, if not for the same condition. So there was stuff to lean on. It was not starting from nowhere.
Yeah, in a sense, I think of it as being the commercial name called Xyrem, and now it's called Xywav. There's a group of physicians around the country that prescribe Xyrem and Xywav, and it's very highly regulated. But there was, they were all used to it. So the idea of prescribing it to another group of patients that they had been seeing already, and some of them had been, prescribing it off-label, that fit. It wasn't too much of a stretch.
So this is a perfect time to ask some of the questions that have been coming in from our various platforms. Lexi Campbell asks, how do scientists decide to treat something with an existing medication? What's the trade-off between a potential therapeutic effect, but maybe it being not such a perfect match? Did you talk to the researchers about that?
For this case, it was kind of trying everything. That in the book, we see that Anna tries conventional stimulants, modafinil. Her doctor offers her drugs for people with Alzheimer's, and then this was sort of a last resort. It's like, we tried everything else. Let's try this. There's, physicians will try just, the more adventurous ones will try it. I mean, depending on the perceived risk. So it's often about if something does work, then making a rationale after the fact.
But so this is another question that's coming from the audience. What are the ethical dimensions of that?
It's always about weighing potential side effects. Like for Anna, there was this drama at the beginning where flumazenil was thought to put someone at risk of having a seizure. And then that didn't happen. And we're very glad that didn't happen. And then even today, like with Xyrem and Xywav, I think they have safety issues, and the physicians who prescribe it are aware of them and want to make sure that their patients are safe.
So I think several people who are watching want to know kind of how Anna's story ends. What's her status? What's her condition now?
Well, Anna is a successful lawyer in Atlanta. She's married. She has a son. I have not met her son, but I remember seeing a video of him running around. She as far as I know, still takes flumazenil. And so she's kind of the success story, but she never really, like, she didn't want to become kind of the voice of the community. She was happy to kind of participate in the initial round of publicity, but others took it further.
So there are a lot of characters in this story, and particularly because there's not one single person to carry forth the narrative. We have another question from Nolan Shaw, who asks, how do you balance telling patient stories while also giving the underlying science its due? And let's face it, neuroscience is kind of gnarly science for the average person. I mean, I just had to make you explain what a neurotransmitter is.
I don't think
So how did you balance this?
I don't think I did adequately. It's a matter of not giving too many details at once, not explain. At the beginning of this, I didn't know all the different parts of the brain, and I still don't. It's just piece by piece. I still don't consider myself a neuroscientist, even though I know the names of a few parts of the brain.
I can recite the mnemonic for the main nerves. That's about it. You trained as a biochemist. So did that make a difference that you were a scientist first before you were a journalist?
It especially came in handy understanding narcolepsy, which is caused by an overreaction of the immune system. And so my graduate training was about how the immune system develops and all the different molecular parts. So yeah, that's a good. I feel like that prepared me excellently to explain where narcolepsy comes from.
So we're coming close to the end of our hour. And this is the point where I ask people sort of the big overarching questions. What did you learn writing this book? Immersing yourself in these communities, watching a clinical trial unfold, watching the recognition of this condition expand and be taken seriously. What things did you come away with?
I think it made me think a lot, a lot about people living with chronic illnesses and what they need and deserve. It's as far, there's dealing with their insurance company, there's dealing with their doctor, but also dealing with family and friends, and just having them recognize what you're dealing with every day, what they are dealing with every day, and have them see it as real. That was but also and seeing how those communities develop and how all the dynamics within those communities. That I learned a lot about that, about just how scientists and physicians work. I think what I really wanted to do was to put idiopathic hypersomnia's story out there so that other people could kind of fit it into the larger picture of these chronic illnesses, like that you mentioned at the beginning, and kind of compare and contrast and see what has worked and what hasn't.
So I'm going to scoop up one more comment from the audience, because it's something that I think I agree with, which is that what I think you're saying is that your book, you hope, illuminates more than just the community that has dealt with or has researched idiopathic hypersomnia. That it's really, it's a narrative of the problem of chronic illness, especially a sort of orphan chronic illness that isn't well understood or recognized, that you're giving people
sort of the average person a sense of what it's like to live inside a condition like that and how challenging it is. I mean, is that right? Are you hoping that people read that and read this and take that away?
Yeah, and on the other side, these are things that the disturbing part of it, or kind of unsettling part, is that these medications that are used to help people stay awake always get used by other people. I mean, that happens with amphetamines. That happened with modafinil, which was kind of developed 20, 30 years ago for narcolepsy initially, and then got used by lots of other people. And then now there's a class of drugs that is still experimental, called either hypocretin or orexin agonists. So people with narcolepsy are, at least a certain form of it, their brains don't make a certain peptide that helps them stay awake. And these drugs kind of mimic that, or they try to replace it. And so this is something that the narcolepsy community has been interested in for a long time. But everything that gets developed for that purpose always gets used by, fighter pilots, surgeons, college students, everybody else who wants to stay awake, right? So I wonder what happens when some of these actually make it out there. That's still for the future.
That seems like a good place to stop. Quinn, thank you so much for spending all this time with us, talking to us about the experience of writing this book and immersing yourself in this community and meeting these researchers and following this very complex narrative to, if not to its end, then to the stopping point it's originally at now. I'm so glad you joined us. So that's it for this edition of the Health Storytelling Author Q&A series. Please consider following Quinn on social media. You can see his handle on the screen and buy his book. His publisher is Columbia University Press. It's available on their site. It's available on Amazon, of course. And it's also available at bookshop.org, which is kind of the anti-Amazon. It's a platform that funnels orders to independent bookshops. And if you like going to independent bookshops, actually to the stores, we urge you to follow the link we provide for indiebound.com. That site will show you which independent bookstore near you is carrying Quinn's book or can order it for you. So this concludes our first episode in this semester's iteration of the Health Storytelling Project. In future months, as I told you, we'll hear from Jennifer London about American Breakdown, and Amy Doxer Marcus about We the Scientists. This series is hosted by the Center for the Study of Human Health at Emory University, co-sponsored by the Georgia Center for the Book, an affiliate of the Library of Congress, Science Gallery Atlanta, and the Decatur Book Festival. On behalf of all our sponsors, and from Emory and from me, thank you for watching. See you next month.